Thank you. I'll now try to connect via the Facebook so that we can have a live streaming. We're already being recorded. Hello, everyone. Hi, Jean-Louis. Hi, David.
Can you hear me?
Yes, I can hear you.
Good.
Yes, I'll try now just to connect via Facebook. Let's see. But we are already recording our section, so if the Facebook doesn't work, we'll have the recording anyway.
Okay.
Bonjour, everyone.
Hello.
Hi, Jean-Louis.
Hi.
Just waiting for other participants. We have 2 minutes, so they might be arriving very soon, hopefully. The live stream is not responding. It's just keep on moving that ball, just trying to make the connection. Anyway, I'll leave it there, and if it just get started, it will. So let's see if you have more people now waiting there. Yes. Okay. We're still waiting for Stephen, Vera, Jerry. Let's give them just 1 minute. Okay, Jerry's in now. Half minute then. Stephen, the British one will be a late comer. Oh, we have other Brits here as well, so it's fine. Right. Anyway, we start. We're very happy to have our first section about the issue we have proposed. Yes, and just a quick word, just before we start, and I give the word to Nick, who will share the first session. We are a group of researchers that got together to publish their papers in a themed issue on policy capacity and health system strengthening. The main issue, question of this issue is to see how and if indeed the policy capacity is a very important variable to see if and how they impact system strengthening, impact the health systems, even using other concepts like David Hunter has done, using transformation, system transformation concepts. So one question that might rise is, so how to manage the relationships between those two broad concepts coming from policy capacity and health system impact, transformation, and strengthening. So those concepts, they might come not only from the health system, but from the public policy system as well. Just remember that this is a public policy journal. It's not a health policy or health system research journal. So just keep the mingle, the connection, all the time in your paper, at the beginning, at the middle, and at the end. Just keep the connection with public policy concepts. Keep the connection, don't lose it. Just keep the connection with the policy capacity framework, even for saying, if you have to say that, look, in my case, it does not work well. So the other concepts are more prevalent. So, but keep it going. And at the end, you bring some light about it. Yeah, just saying, oh, I try to use the policy capacity concept, but not work well because I found all the relevant elements that connection better with public policy and health systems transformation or strengthening or resilience. Just keep on just moving in relation to those concepts. I'm very much looking forward to see the presentation of papers which are brilliant, very innovative, and bring us just different ways of making those connections. So please, if you're not presenting a paper or not a discussion schedule, you can start making comments or questions via the chat here. And at the end, the chair will also ask if anyone who would like to have a question. So Nick is with you now. Nick Turnbull from the University of Manchester will be sharing the first section. Thank you all.
Fabiana, maybe just a suggestion, maybe
Yes.
when we don't speak, we can close the video and the microphone to ease the connection.
Okay, yes, you can do that. Yeah. It depends also on your connection, maybe, but you can close the microphone definitely, so that we won't have other noises around. Yes, dogs barking, people eating, and music. Thank you. Hi, Nick.
Hi, Fabiana. Okay, thanks very much to Fabiana for organizing this. It's obviously been as disrupted as everybody else has been, so it's great that we could still have the meeting and go ahead with the project. First up, we're going to have David Hunter. Rafael, I take it, is not coming to present, or maybe he is, David? You have to unmute yourself.
Yes, he should be coming. He said he
okay.
That's joining.
Fabiana will admit people as they come.
Okay.
We'll have David and Rafael be presenting their paper on the World Health Organization research, which they've already supplied, and you can take a look at from the Dropbox. So as Fabiana said, if you want to ask a question, feel free to write it in the chat, and I will make a note of the question, and then I can either ask it at the end, or if you want, you can come on video and put your actual hand up when it's done, or you can use the raise your hand facility. If you click on participants in Zoom, then you can click that little raise your hand button. But I think it's just as easy to simply write a question in the chat, and we'll go from there. So we'll all mute ourselves while David and Rafael are presenting. They have 20 minutes to present, and then hopefully we'll have Gerald and also Stephen to give their discussion afterwards, a little bit of general discussion before we get to Vera chairing the next section. Okay, so David in Newcastle, very happy to hand over to you to present the paper.
Thanks, Nick. I did have some slides, but I'm not sure I can get these up.
You should be able to try share screen.
Yeah, but then what happens? I get Dropbox, Microsoft OneDrive, Google Drive, and Box.
It doesn't give you the option of going to a PowerPoint. If you've opened your PowerPoint, you might be able to share screen that way.
Right, let me see.
So yeah, open the slides first.
Yeah, I'm going to do that now.
Yeah.
Here we go. Yeah, I've opened them now.
Okay, so now if you press share screen, you should be able to select PowerPoint.
Oh, hang on. Doesn't seem to want me to do that. Oh, for goodness sake, it's saying connect to Google Drive.
I guess the other option is to email the slides to Fabiana.
I did that yesterday, so I don't know if Fabiana can bring them up. Can you, Fabiana? She's muted. Can she unmute herself? I did send them to her yesterday, so.
She's trying to do it, I think.
Oh, she's got her thumb up.
Yeah, good news.
Sorry about this. Last time
I'm doing it. I'm sending it to David. Just a second. Yeah.
You're putting it up, right? Great.
Yeah. Yeah. So now here in program, the slide is, yeah, and I'm sending to both of you just in case. It to David and to Jean-Louis aussi.
So where will I find this?
In your inbox. It's uploading now. Just one sec.
No, this isn't working.
Just one second. Okay. It's gone now. It's there, might work.
No, I can't get it. I can't find it. I can't seem to.
Just send it. Try again. Sorry.
Yes, I have it, but how do I get it onto the system?
All right. You want me to send via chat here? I sent
so,
it on inbox to your email.
Yes,
Have a look there.
yes,
yeah,
I have it. I can't get onto my files though from the share screen.
So I'm
Fabiana.
sending it via the chat now. Sorry, David.
okay.
Okay.
Have you emailed it, Fabiana?
Yes. Huh.
Okay, I don't have it yet.
Fabiana, there are a couple of messages in the chat which may have alternative solutions.
The other thing is, yeah, send it to everyone, Fabiana, and then
Yeah.
you can just look at it as they.
Yeah, I'll just speak to it.
All right, so Fabiana, why don't you try and send that to everybody, and
Yeah.
David, why don't you just start talking from the
I will.
slide on your screen, and then we can come back to them as we go.
That's fine. Right. Oh.
I attached it. It's just getting through. It's going.
Okay.
Going to everybody.
It's 0.5% of it because it's a bit slow now, but it's going. 8%. Sorry. It's in the PowerPoint format. 90%. So might be there in the chat at any minute. Gone. It's there, David, in the chat.
Oh, hang on. Right. Let me come out of
So
this.
you can pick it up.
Let me get out of this. It's in the chat.
Yeah.
Oh, yeah, there we are. So I can open it here then.
Can you open it?
Let me see. Oh, for goodness sake. Open file. Right.
Yeah. Have
You see it?
Yeah.
It's on now.
Good.
Right. So I've had almost most of my 20 minutes now.
No, you can start from now. Not a problem.
I'll start from now. Right. Okay.
Yeah.
Okay. I hope everyone's had a chance to look at the paper in Dropbox. This is just a very quick.
I can't see the.
Can't see them.
No, no.
Oh.
Do you see it, Fabiana?
Either you have to go to share screen, or it's not. You can now download it. I've opened it on my screen.
Yeah.
That's from me. Can you see that?
Oh, I can now. Yes.
Okay.
Right.
So if you give me a shout, David, I will talk. I will move the slides as you talk.
You'll move the slides to the top. Right. Okay. Well, sorry about all this. They're there now. I hope you've had a chance to look at the paper in the Dropbox. I'm just going to pick out some key issues based on this project Rafael and I have been doing for WHO in Europe. The next slide. just shows what I'm going to cover very quickly, our definition of what we think health system transformation is, why it's become an issue in many countries, why we've tended in policy analysis to think about the why and the what of health issues rather than the how we bring about change. And then finally, how we attempt to bridge that no-do gap in terms of policy and implementation. Next slide. The definition we took is based on Alan Best's work in Canada, looking at large system transformation in healthcare. I won't read this, but essentially we're talking about whole system change affecting a number of organizations and professional groups with the aim of improving healthcare delivery and population health outcomes. Next slide. Someone's commenting on my voice cutting in and out. I'm sorry about that. I think it's my microphone. You'll have to bear with me. I will try and speak up, but I don't think I can do anything about that at the moment. Basically, there are three eras of global health system change. We've taken this work from an American group looking at how health policy and healthcare challenges have changed over the years. And where we are today is looking at the whole life course in health, involving health care, but also population health in terms of tackling the social determinants of health and improving health inequalities. Next slide, please. As a result of the increasingly complex environment in health policy, there are a number of issues that are confronting health systems, rapid changes in medical science technology, more information, a move to dissolve or at least make differences work between organizations and professional boundaries. There's a kind of blurring of those boundaries, a dissolving of them. There's much more interconnectedness of systems across health, healthcare and social care. Populations are affected by multimorbidities in a way they didn't used to be. Non-communicable disease is on the increase. Much of it's lifestyle related. There are many new procedures, drug interventions, and so on. So it's a very complex environment. And the point is that many of those leading organizations in health policy find it difficult to address these complexities in a systematic way. And as a result, there's an increase in the possibility of implementation failure. Next slide, please. The literature suggests a number of explanations. This isn't an exhaustive list, just a few of the more common explanations for policy failure. Overly optimistic expectations from policy. Secondly, what has been termed operational disconnect, the disconnection between those making policy and those implementing it, with very little dialogue or discourse between them. Inadequate collaborative policy making. Lots of governments suffer from departmentalitis, where policy is crafted in departmental silos, lack of collaboration across departments. The political cycle, short-term electoral pressures create difficulties in sustaining policy over the long term. And finally, what one might call a focus on the front end of policy making, setting the agenda, dealing with the why and the what, but neglecting the how, neglecting implementation. Next slide, please. So this work for WHO was basically focusing on the how and not the what of change. And to do that, we reviewed a number of frameworks and adopted the receptive context for change developed by Andrew Pettigrew and colleagues back in 1992 when Andrew was based at Warwick University. And we tested this framework out at a couple of meetings in Madrid and Durham in 2015 and 2017 respectively, where we convened a group of 30-odd policymakers and academics from across Europe to discuss this agenda of how we bring about successful health system transformation. Next slide, please. And these two reports have been published by WHO. So you can look at the detail of the discussions in those. Next slide, please. We, in the paper, refer to the policy capacity typology developed by Wu and colleagues, which is made up, as you all know, of 3 types of skills and operating at 3 different levels. Next slide, please. But we reckon that the framework we'd adopted, the Pettigrew framework, which is actually made up of 8 factors, but we selected 5 as being critical, we reckon this receptive context for change encapsulates the Wu policy capacity typology within these 5 components. Next slide, please. I'll come to each of the components in a moment, but I wanted just to emphasize that we feel that underpinning the framework is what we call the 3 C's, context, complexity, and culture, and that we're particularly concerned about the context within the health system framework, the context in which health systems operate, the wider context. It might be political, but it could be other factors as well. We're concerned about the increased complexity of health system change, and we're concerned about the culture that operates within health systems to enable or to hinder change. So going through the factors very quickly, factor 1, next slide please. I won't read these, but these are quick definitions of the factors. And as I say, we think that all of the elements of the Wu et al. Policy capacity framework are in those factors. That's the second one, how coherent and aligned policy is. Third factor, issue about leadership and change being important, critical. Organisational culture, very important in healthcare systems. We have just professional groups operating in very complex settings. Fifth factor is the relationship between management and healthcare professionals. Again, an issue of major importance in healthcare systems. And the next slide, please. These factors are not individually discrete. They operate together. They should be viewed as interrelated. And successful change requires alignment between those factors. If they push and pull in different directions, then achieving change is likely to fail. Whereas if they are facing the same direction and are well aligned, the chances of success are much higher. But despite all that, as Pettigrew and colleagues say, at the end of the day, there's no simple recipe or quick fix in managing complex change. Next slide, please. We also borrowed a little bit on John Kingdon's model of multiple streams to emphasize this issue about alignment. If the 3 Ps, problem, policy, and political stream are all aligned, the chances are you'll get change and a window of opportunity will present itself. If any of those streams are unaligned, the chances are change will not be successful. So it's not enough simply to have the problem and the policy streams in place, you also have to have the political stream as well. And the same applies to the others. So you need some alignment between those 3 Ps to bring about change. And we thought the Kingdon model quite nicely summarized much of what Andrew Pettigrew and co were trying to do in their receptive context change framework. Next slide, please. We visited 3 countries for the case studies that WHO supported. We could expand this list, but in the first phase of work, we restricted ourselves to these 3 countries where major change was being contemplated: Sweden, England, and Portugal. I won't go through the details of those changes. We set them out in the paper, but essentially there are major challenges facing the governments in those countries who want to do something about health system change. Next slide, please. Second last slide, I just want to pull out some of the themes that were common across the 3 countries. We developed these in the paper across the 5 factors I've just mentioned, but just bringing all these together across the countries, it's quite clear that in each of the countries there was a burning platform which served as a driver for change, something that governments felt needed urgent and critical attention in regard to triggering change processes. That might be pressures on hospitals, funding pressures, growing inequalities, a need to get a grip on public health issues, population health, whatever the factors, they did serve as a kind of burning platform to drive change. Legislative change was an issue in Portugal more than it was in Sweden and England, where the feeling was that change should and could occur without legislative change to support that, at least not in the first instance. Evidence, variable, I think, in terms of its role in the reform agenda, useful to support existing policy preferences rather than challenging those. So selectively cited, I think, to support change. The political space for change, I think, was very important in both Sweden and England. And I've noted the role of the chief executive in England and the NHS, because I think that particular appointment was critical in enabling change to occur that might not otherwise have occurred. And we developed that in the paper. Having said that, I think in both Sweden and England, and to some extent Portugal, there was widespread buy-in to the reform agenda from professional groups, more so in Sweden and England than in Portugal. In the countries, there was this tension between loose-tight, between being tight on outcomes and loose on means. In the English case, this was somewhat counterintuitive, because most of policymaking in the English health system has been very much based on command and control, top-down direction, where there's been a certain looseness about outcomes, but a very tight grip on means of bringing about change. The idea now, under the changes underway, is to try and reverse that and allow people on the ground locally to develop new models of care and find new solutions to existing problems. We talk a lot about leadership and the importance of leadership styles and the move towards more adaptive and distributed leadership styles across whole systems, across whole communities. And that is something that came through very strongly in both Sweden and England, especially England. Implementation support is important, that if governments want to see change succeed, they have to invest in supporting implementation through different means. And one of the levers there is additional funding, transformation funding, to help the change process. So those are some of the themes. There are a lot more that we've picked out of our 3 case studies, and they're reviewed in the paper. Those are some of the key ones. Just some conclusions, because obviously all this is now taking place against a very different context than it was even in January of this year, when we finished the Portuguese case study, and certainly last year. So we do face a very uncertain future. We can't predict events, as we've seen in the last couple of months. The unexpected will happen. It just has happened with COVID-19. There is a need for an acknowledgement of context changing and political flexibility being required, and we've seen evidence of that in the last few months in many countries. I think it's fair to say that governments haven't been, in general, well prepared for this crisis, but also for many of the other pressures that face healthcare systems. That planning has not been much in evidence. We also know that plans have unintended consequences, and therefore one has to be attentive to those. And then finally, a message from our work is that it's fine to have strategies and plans and directions you want to move in, but you have to admit that there's a need for often adjustment, modification, course correction along the way, that incremental decisions are not necessarily a bad thing. Muddling through is not necessarily to be avoided, but we do have to acknowledge that adaptive change and handling complexity means being flexible and being, again, loose about the means, but tight about where you want to get to at the end of the day, what the purpose of that reform is, if you want to ensure implementation of the policy at the end of the day. So that's a very quick canter through some of the complexities that we've tried to address in the paper.
Okay, thank you very much, David. I appreciate you had to rush because we were slow getting going. Rafael, welcome along. Did you want to add anything else?
Yes. Can you hear me okay? We're better than David?
Yes.
Well, you can't hear David very well because of the Brexit thing, so he keeps on coming on and off. As you know, in other parts, they're trying to leave the right place. just 2 points. Most documents that we got when we visited the countries did not talk about how. They were mostly about what. They actually went into very deep complexities about what had to happen in reform transformation in that country. So much that when we went in and we started talking about implementation, they kept on wanting to talk about what they were going to do rather than how they were and what they were learning about how. So we had to draw it out. You have to. You have to draw it out because they don't. Most of our countries, or at least these 3 countries, and I would add my own in Spain, don't think enough about implementation. So that's basically why we're so obsessive about trying to get this work and this paper out in relation to how and what can we all learn about how people are doing things at the policy level, which is where we focused mostly at the policy level. Because I think intuitively, I think we all see, and I think after when we talk about Jean-Louis Denis and the others in his colleagues' paper, the obsession is very much that something is missing at that policy level, and that something much more, let's say, forceful has to happen at that level. Not necessarily legislation, but something much more, a greater, let's say, capacity has to happen at that level. And then the point that David insisted on, this interesting thing that most of the people that we spoke to in these 3 countries are comfortable with a more adaptive approach versus what they would have thought 10 years ago in relation to much more detailed planning, etc. So I would leave it at that, and just thank you all for listening in.
Okay, great. That's a very interesting and very interesting comments there, Rafael. Now we're catching up on time. We're doing quite well. I'll hand it over now to Gerald in his role as discussant. We don't have Stephen, so Gerald, you've got a few extra minutes before general questions.
All right. Well, first, I should say thank you to Fabiana and others for giving me the opportunity to participate. I think this is a really fascinating piece of work. I also thought that this was a very good paper to start with, and I'll say why. But first, I live in England. I live in Britain. So what is described in the paper is very familiar to me, but most of my work is in low and middle income countries that have mixed health systems, public-private, with relatively undeveloped or underdeveloped institutional arrangements. And so this colors how I look at this. I think one of the key points, and Fabiana wants us to link it to that paper by Wu et al., comes in the word she used and the word that David used. I mean, this isn't about health system strengthening, it's about transformation. And what David describes is everyone knows where they want to go. We know where we want to go. The problem is, how do we get there? And it's a challenge of managing change, and the other concept that David has brought in a complex environment, which is in a context of very rapid change. And he mentioned that he had a whole slew of them, demographic change, a lot of technological change now, which is going to change how health systems are organized. And then he mentioned at the end, and it's true, he mentioned exogenous shocks, and COVID-19 is kind of staring out at us at the moment, but almost the bigger one that's going to be coming is the major recession that's coming, which will have a lot of impact on any transition or transformation activities. So we're talking about how does one manage transformation in a context of rapid change where we're likely to experience all sorts of shocks. Now, what does this mean for our understanding of capabilities? And I read Wu et al. From that perspective of the context I know, and they have a 3x3 matrix, and it seems to imply you could map capabilities. I can almost see a rather stable system mapped. I mean, there are politics, that's politicians. There's operation, oh, that's civil servants. And there's analyses, that's think tanks and researchers. So we have capabilities and established institutions who are going to be undertaking these capabilities. But this paper is asking, and I guess the question I would ask in my context, this sounds like a very static view. How much are those institutionalized capabilities a block to transformation as opposed to a facilitation of it? How do we understand where are these capabilities and where are they situated in a context of rapid change? Can we really map them onto these particular kinds of institutions? I think it's a question and we may want to look at it. The other thing they mentioned, and it's sort of one of my hobby horses, is you know, when we talk about the capabilities, it's sort of health sector capabilities. But the paper says, well, we've got to look at collaboration across sectors. And one that sort of jumps out at me is the internet platforms, who are going to become more and more important in digital health initiatives. So they clearly have to be part of this process, which means that private sector and public sector are part of this environment we're now talking about. So where are the capabilities now going to be sitting, and what's important for managing change? And the paper brings up this whole question of dispersed leadership, dispersed capacity for analysis of change. So I think there's a lot of issues that really enrich that initial matrix. And then they bring up, and it would be good to have discussions over the next month or so on all these issues about change processes and timing. They bring up urgency, the importance of quick wins, windows of opportunity, the importance of shared narratives and visions, much more in the change management literature than I guess in the standard policy capability. And I think it's about the interaction between the two that maybe the papers are going to really contribute. And the last point I made here, and I'll be involved with Louis Husseina, who is also in the meeting looking at China, where the focus has been almost entirely on the how rather than the where do we want to go. And the other issue that they've raised at the end is the learning by doing and the learning in context of uncertainty. So I think it's a great start, and it's brought up a lot of the issues that I think that the subsequent papers will be engaging with.
Great, very insightful. Thank you very much, Gerald. Stephen is now here. Stephen, you okay if we go over to you for your quick discussants comments? You have to unmute yourself if you're there. Maybe.
Yeah, there we go. Just waiting for it to unmute. Okay, sorry to late, but I didn't seem to get a confirmation email. So I've only just caught the end of Jerry's comments. And some of what he's literally just said, I think I would definitely say. I thought this was a good paper, David, and quite an interesting one, looking at comparison, and you open it with a reflection, obviously, on COVID, and I do wonder whether some of them, what follows, might want to be revised. I've been quite taken, as Fabiana knows, with some of Paul Kearney's commentary on how systems or policy systems are responding to the whole COVID issue. In terms, I think, I only caught the end of what Jerry was saying, but something about this ability to kind of do transformation under pressure at particular times. I do find sometimes thinking about the kingdom policy streams and processes sometimes a little bit rigid and constraining when we look at how systems transform. And I think that applies as much to the UK, which is often seen as a way of looking at the way that as looking at a kind of looking at it through a kingdom type lens. But I do wonder whether we don't take into account how shocks to the system, and so some of Carolyn Tui's work on institutional entrepreneurs, for example, which I think is very relevant to the UK, but also system shocks like COVID can actually change things quite rapidly. And I think that does push you, I mean, as you and I, we've talked a lot about that kind of interface between implementation, so system transformation in terms of implementation, and what I caught at the end of Jerry's, thinking about some of the structures for change management, and that intersection between the two. I thought the 3 case studies were quite interesting in terms of the way that systems evolve. I just wonder sometimes, I mean, and particularly when we think about it, particularly perhaps outside of a European context, I suppose, is how far the kind of that inner outer context that we start with, which I particularly like as well, is relevant, and also the strength of the 3 streams is as relevant to other systems which might not be, I think, probably say as stable perhaps as European systems, although I do wonder whether sometimes European systems are always that stable. So I think there is something there, but Paul Kearney I quite like, because he does draw a little bit more on, he's a little bit more eclectic the way he draws across some of the policy interpretation models, and he's actually written quite an interesting piece, evolving pieces around the COVID crisis, which might be worth looking at as well, in terms of the way that systems both alter but how you embed things. And I think, again, Jerry's just said some of the way things are changing in respect to COVID at the moment demonstrate that even fairly turgid systems have a reflexivity built into them when needed to adapt in crisis. Now, how much of that is actually driven at a policy level and how much is just driven by practice, I think, is a question you can ask, particularly in the UK sense, where often policy tends to have to catch up with things that are going on the ground. So that kind of broader, wider impact of the local system on what happens nationally. There was always that discussion in the UK about policy actually restraining innovations and change rather than always promoting innovations and change. And I think maybe a little bit of pulling out of some of those sorts of things might be quite interesting. So that's some fairly brief comments, but I mean, yeah, I liked the paper. I thought it was interesting and quite useful, given the work that we've been doing recently as well.
Okay, thank you very much, Stephen. That's really great comments. We need to wrap up very soon to move to the next paper, but I believe Alex Shanklin has a quick question to ask of the authors. Alex?
Thanks, no, I didn't. Other than to express general appreciation and interest, and to second Stephen's comment that we're in a time when it's very hard to categorize health systems as stable or unstable. And I think that's linking policy capacity to question of resilience is a really interesting area to be discussing. But no, I hadn't got a specific question. I'm not sure if my hand was up by accident or not up. I'm not sure.
Okay, that's okay. Absolutely, thank you very much. David, Rafael, is there anything you want to wrap up with very quickly, just at the end?
Well, thank you for those comments. Rafael and I will reflect on them. Just in response to Stephen's comment, we're very mindful of COVID-19. We're also mindful that our case studies preceded it. So how we link what may or may not happen as a result of COVID-19 to what we've done, I think is an interesting issue we need to reflect on. We also don't know whether COVID-19 will have permanent impacts on health systems, or whether we will revert to a default position at some point in relation to much of the policy energy that's now being exuded. It may well be that some of that dissipates and we end up in reverting back to a path dependency model of health system change. So I think we're at an interesting juncture, critical juncture, in terms of whether COVID-19 will have a lasting impact, or whether it's a temporary blip, depending on how things unfold. But I think it's something for Rafael and myself to think about and reflect on.
Absolutely.
Can I just come back on that? Yeah, I mean, I think you're right, David. I think that there is a possibility that particularly I think in the UK that the system will revert to form in a way. I think the only probably correlate to that. And I think it's the same way that the policy shifted very quickly to integrated care through the intervention of creating NHS England as a strong institutional entrepreneur in the system. And I just wonder, actually, if out of the COVID you get a kind of a new sense of that coming in, then possibly you might. So I suppose, yeah, but otherwise, yeah, I agree. I think there is a danger in England of revert to form.
Okay, I think what we should do now is, Fabiana, I think we move on, and if there's any questions at the end, we come back and we see if we can wrap up as a whole paper. So Vera, over to you.
Okay, thank you. Good morning for some of us, good afternoon for others. I think no one is at night, no? I want to thank very much Fabiana for organizing the workshop, and for her, for Stefan and Jerry for working in organizing the special issue. I also want to thank a lot the authors for bringing a very interesting panorama of process of health system reform that are happening in different countries, and to congratulate the authors that are really working with the framework that Fabiana recommended. So it's not easy, you know, to do, and I can see things going on. So let's move to our second paper, Health Reform and Policy Capacity, the Canadian Experience, authored by Jean-Louis Denis from the University of Montreal, Susan Usher from the National School of Public Administration, and Joanne Prevel from the University of Montreal. Please, 20 minutes, and then we go on for comments and discussion, okay?
Okay, thank you. Can you see my slide?
Yeah, perfect.
Okay, so thank you. So I want first to thank my co-authors, Suzanne and Joanne. They are online, so they may step in at the end of the presentation. So the paper I will present is a kind of companion paper of another one that will appear soon in Health Economics Policy and Law, where we look at the key objective that each Canadian province pursue in health reform and their main strategies to achieve these objectives. And in this presentation, we use these empirical material to look at the meaning of policy capacity within the context of Canadian health reform and the manifestation of these capacity in processes of change. So, as probably some of you know well, I spent most of my academic career focusing on the how and not on the why, and a good attention has been paid to organizational dynamic and implementation dynamic. And then we decide to move up our research to what we call policy work. So how people in government and in their network work to craft reform, and how they try or not to anticipate implementation challenge. So some of these concerns are embedded in the presentation. So I will move on now to the presentation. This is the outline. So first, a brief introduction on policy capacity and health reform. And as you know, most of the work on policy capacity have been very definitional up to one, trying to define the dimension. And so we, as the chair underlined, we try to take seriously the Wu and colleague framework on policy capacity and try to apply in the context of health reform. So in the Canadian context, the usual, I will say, obstacle to achieve reform or to improve the health system, I will use it as synonymous in this presentation, has been first political gridlock, like sectoral interest, sectoral value, corporatism, unions, and so on. So the political landscape is seen as being a source of rigidity. then I will not have time to go in detail, but in Canada, we have 10 provinces, 3 territory, each one run their own health system, but they do it in the context of what we call the Canadian Health Act. And the Canadian Health Act, for many analysis like Caroline Towe, Colleen Floyd, and so on, have been seen as a kind of obstacle to drive real reform because it focuses a lot on hospital and medical care and probably neglect other dimension or priority. Then the recent report 2018 commissioned by the federal government conclude that wide set of persisting vulnerability of Canadian health system despite successive wave of reform. And these vulnerability persists in a context where there is a kind of division of labor between federal and provincial stewardship on health system and health system strengthening. So one of the question is how policy capacity may help, why and under which condition, and how in such a difficult terrain of health reform. And that's the thing we try to tackle in this paper. So some contextual element influence the supply of policy capacity. So, and I will revisit this in the end, but political regime like federalism versus unitary state. You may remember that during the Obama reform, like the federal government has to put some expert team at the federal level to help some state to implement the Obamacare reform because they estimate that they have not the capacity to do it. Another aspect that influences the supply of policy capacity are predominant policy frame, the classical case, which is underlined in David and colleague paper, is the distinction between producing care versus producing health. And depending how policymaker and politics relate to these distinctions, it will impact on the way we will define needed capacity and effort that we will do to develop them. Then we have another aspect is the predominant beliefs about problems and solutions. And just to make it short, if we sit around the table with an economist, a political scientist, a leader of the medical profession, nursing profession, management, and so on, we will get different framing of problems and solution. And again, it will impact on the way we see policy capacity. And then one last factor is the prevailing view of the policy process. Does the government see it as a more of an open process or a very confined process in some closed policy shop or very sectorial or privileged group that design policy? And finally, as you know well, all this evolve in a kind of political soup defined by predominant ideology and allegiance of the day, including the government that is in power.